Welcome to Grand Rounds for February of 2026. Today we have Dr. Lauren Garges providing us with information about the musculoskeletal syndrome of menopause. Dr. Garges is the program manager of the pelvic floor rehab program at St. Luke's University Health Network and has specialized in pelvic floor dysfunction for 21 years. She is board certified in women's health physical therapy through the American Board of Physical Therapy Specialists and has additional certifications by the Academy of Pelvic Health Physical Therapy in pelvic health and obstetrics. She is also certified in perimenopause and menopausal care by the Integrative Women's Health Institute. Dr. Garges has served as a medical expert related to pelvic dysfunction for Runner's World, Men's Health, Forbes, and Health.com. She teaches at St. Luke's School of Nursing on the topic of postpartum care, mentors many clinicians, and collaborates with other specialties to provide collaborative care. As she personally navigates the female midlife experience, she understands the importance of individualized care as each experience is unique and changing. Dr. Garges is honored to support and serve the women of the Lehigh Valley through all life stages. So as a reminder to everybody, make sure you sign in using either the code on the left side of your screen or the QR code on the right side of your screen. And if you miss that, the codes are all in the invite that this meeting was sent originally. And if you still miss that, let me know and I can send it to you. This is the activity description and the statement of need. And the target audience is all providers. This is our hospital's designation statement. And the planners and presenters have nothing to disclose. So without further ado, I will turn this over to Dr. Garges.
Thank you, Steve. The learning objectives are here, as you can see on the screen. You can feel free to read through them, and hopefully by the end of the presentation, you will feel adequately ready to answer them. So I'm going to get started here. So as I have been studying this topic for the past 2 to 3 years, and also preparing for today, I would say this is kind of a portrait of my head. There is a lot that when we think about this stage of a woman's life, we often refer to it as midlife, but there are a lot of statistics that were really surprising to me as I was researching this topic. First of all, as you can see, about 75 million women in the U.S. are perimenopausal or menopausal. It represents almost a quarter of our population. Of that, though, despite the various numerous symptoms they experience, which we'll talk about, only about 20% of them seek any form of medical help. When they do, they may often see 4 to 5 providers before they are actually accurately diagnosed. The economic impact is significant. About 25% of women with symptoms actually have such severe symptoms that they can no longer carry on their jobs as they are described to be. So there's about a $26 billion impact in the U.S. Economy. From a medical standpoint and provider standpoint, only about 31% of interviewed OBGYN physicians reported that they had menopause education in their training. Of a survey that was taken in 2025, only 20% of OBGYN residents felt ready to help women navigate the menopausal changes. And one thing we'll talk about towards the end of today is a very common treatment for this that helps about 90% of women is menopausal hormone therapy. Although as of 2024, so about a year and a half ago, less than 8% of women were utilizing this. And we'll talk about the reasons why as I go through. So let's define menopause. What is it? So menopause is really the end of a woman's reproductive life. So it's when she has fully stopped menstruating. The median age in the US, I've heard a couple statistics, but the average looks to be around 52 years old. And what has come to pass really over the past 100 years is that women are living longer. So, centuries ago, women really didn't live much longer past the stage of menopause. Now, many women spend over 40% of their lives in this state. And currently in the US, over 60% survive past the years of the age of 80. So it's really something that hasn't been studied very well. A lot of the reason being that this has only happened in the past few dozen decades, really, that women have lived this long. There are three main stages of this change in a woman's life. So if we look at the graph here, you can see the ages on the x-axis. And so really in the 20s and 30s, women are living in their reproductive years. And if you look at the green and yellow lines there on the left-hand side, that represents the two main reproductive hormones, estrogen and progesterone. In the stage of perimenopause, this is when estrogen levels really start to dramatically drop, and you can appreciate that here in the graph. Menopause itself is actually one day in a woman's life. So it is the 366th day since her last menstrual period. So, you have to go a whole year with no period, and when you've met that mark, you are then menopausal. After that day, you are considered to be in postmenopause. And this is the rest of a woman's life. Symptoms in that phase can continue, though, for another 10 to 20 years. So joy. Yeah, we'll talk about all these things. But I would say nomenclature is important. We very rarely actually use the term postmenopause. So if you hear someone mention menopause, or if you hear me even mention menopause, I am generally referring to the postmenopausal state. We don't usually use the word postmenopause too often, but when we're looking at true definitions, that is what it is. There's a couple things to kind of think about here when we look at kind of this roadmap of this stage of a woman's life. So, perimenopause, again, is that first stage of these changes within a woman's life. As you can see here, symptoms can last anywhere from 4 to 10 years. It's a very erratic time of hormone instability. And that's varies as far as how old women are when this occurs. There is a condition called premature ovarian insufficiency. And this is when a female actually stops menstruating before the age of 40. The incidence is relatively rare, but it is fairly significant from a medical standpoint because, as you will see, estrogen is very protective of many systems in the body. So if a woman has her period and her estrogen levels, or I'm sorry, if her woman stops her period before 40 and her estrogen levels are significantly low at that point, it puts her at a high risk of a number of medical issues. Having a final period between the ages of 40 to 45 years old would be defined as early menopause. You can see natural menopause is usually around the age of 51 to 52. And late menopausal onset is if a woman is menstruating until after the age of 55. Again, menopause itself is 12 months with no period. And this can happen for medical reasons or surgical reasons. So if it's not a natural onset, it's either due to something like chemotherapy, which can often be a surgical reason that a woman would stop getting her period, or if she has a hysterectomy in which her ovaries are removed. If you're talking to patients about hysterectomies, it's a good idea to ask them if they preserved the ovaries or removed the ovaries because estrogen is produced in the ovaries. So most of the time, physicians and surgeons will choose to leave the ovaries in place so that a woman is not, placed into surgical menopause, which is immediate. But if there is something like ovarian cancer or uterine cancer, they may have that. They may have their ovaries removed. So it's a good question to ask your patients. Here we can see a little bit of a complicated, messy graph, and this is kind of what perimenopause feels like. It can be a little complicated and messy feeling. I want you to look at the purple line there. That represents estradiol. Estradiol is the most prominent form of estrogen. There are three types of estrogen, but estradiol, which is sometimes called E2, is the most prevalent form of estrogen during a woman's reproductive years. If you look at the y-axis there and you see before puberty, the number is low. As a woman enters into puberty, you can see those kind of little hiccups there, and that's kind of that erratic, hormonal period. Then we get into premenopause, and estradiol remains very steady in this time. Women's periods should be predictable. They should be a cycle of anywhere between 24 and 34 days, and hormones stay in a relatively steady state. I then have circled the perimenopausal state. And if you look at what happens here, estrogen is up, down, and all around. It is quite erratic in this time frame. And this is a reason why doing blood tests to see what your estrogen levels are is actually not recommended. There's no evidence to support that blood work would be helpful in the perimenopausal state to find out what your hormone levels where your hormone levels are. There are companies out there that are willing to do this. I would say there is not evidence to support that at this time. And that's because on one day, your estrogen levels can be quite high, and literally 24 hours later, they can measure quite low. This often just explains wide mood shifts and, kind of a lot of erratic brain fog and things like that. It's just this phase of a lot of change and a lot of hormone unpredictability. Once we enter postmenopause, really our hormone levels level out again at a very low, steady state. So what does estrogen do? I'm going to talk about the top three right here because the bottom three we will be discussing related to the musculoskeletal system. So certainly estrogen does support brain health. It is critical for synaptic health. It helps with neurotransmitter regulation and supports our mitochondria. So it's absolutely neuroprotective. When the estrogen levels begin to go down, women may find themselves with having some difficulty with short-term memory, and it can later lead to some neurodegenerative disease later in life. Temperature regulation. The estrogen in our body keeps our hypothalamic thermostat stable. When it's sufficient, the brain really keeps us within a pretty narrow temperature zone. But when estrogen begins to lower, we can experience like even small internal changes become quite sensitive to them. And that's when sweating, flushing, heat surges can begin, the lovely hot flashes that we hear about. Also sleeping. This is a time when a lot of women will state they'll be doing that 3 a.m. wake up, and they may have slept well their whole life, but all of a sudden they're finding that they're tossing, turning, their minds are not shutting off, and they're not entering into deep sleep. Really, estrogen helps to calm down our nighttime thermoregulation and helps with serotonin to help us to sleep. So during a low estrogen state, it's really when this can really be impacted. I know bone loss and collagen production and the inflammation that can occur, I'm going to talk about in just a few slides. I took this image off of just Google, found, kind of common menopause symptoms. And these are the things that many of us, I think of. Hot flashes, night sweats, irregular periods, brain fog, like I've mentioned, mood changes, low libido. These are all very common findings. One thing you do not see here is actually anything related to the musculoskeletal syndrome. And there was a study done in 2024 of over 480,000 participants, as you can see, and joint and muscular discomfort was the most common symptom. And yet it's not thought of often when we think of menopausal symptoms or perimenopausal symptoms. So it's why I'm really glad to be able to do this talk today. I thank you for attending because it absolutely impacts a huge percentage of our patient population. So let's talk about it. What is the musculoskeletal syndrome of menopause? This term came about from Dr. Vonda Wright. She is an orthopedic surgeon, and she published an article in the journal Climacteric, which is the journal of the International Menopause Society, in July of 2024. First time this term was ever used. According to Dr. Wright, The rapid loss of estrogen during perimenopause and menopause triggers a cascade of effects on bones, joints, and muscles. So it's not just that these are age-related changes, but these are actually hormone-related changes, and they have a drastic impact on our bodies. What are the symptoms that women experience during this phase? These look very much like kind of what we see within among our older patients, right? So joint pain, stiffness, inflammatory flare-ups, things like tendonitis, bursitis, frozen shoulder, as you can see. Loss of muscle mass and endurance and strength, changes in mobility, flexibility, range of motion, slower gait speed, and certainly women are at a higher fall risk. They can begin to have worsening osteoarthritis. There is an increased risk of fractures, including vertebral fractures. And I think many of us have probably seen some women at some point with severe osteoporosis in which their spine is extremely forward flexed from compression fractures. So this that's one of the things that likely may be related to her low estrogen state. And then changes in body composition, fat redistribution. We'll talk a little bit about this. We tend to gain more visceral fat and less subcutaneous fat, and that can have an impact as well. Over 70% of midlife women will experience one or more form of musculoskeletal syndrome. About 25% will have such severe symptoms that they will need to stop their vocation. So that to me was pretty significant. 1 in 4 women will not be able to continue with her job. This is according to the research that Dr. Wright did. And approximately 40% of patients who present with these symptoms will have no structural cause for the pain. So I think we need to kind of circle and highlight that one. This is a really important thing as physical therapists for us to consider. We want to find out, the why and the what and the how of injury. And a lot of women, almost 1 in 2, will have no explanation for their pain. Imaging will be normal. There will not be a lot of special tests that can necessarily explain why they're having some pain. And often it is a very sudden onset, so much so that a woman could go to bed feeling fine one night and literally wake up the next day and have pain, especially in the shoulders or the knees, which we will talk about. So this graphic that you see here covers the 5 different symptoms that are explained in the musculoskeletal syndrome of menopause: inflammation, sarcopenia, breakdown of cartilage, loss of bone density, and decreased stem cells. So I'll talk about each one here. Number 1, inflammation, which kind of cascades and affects all of the other symptoms that we've just saw there. Dr. Wright refers to this as inflammaging, and she actually wrote an excellent book, which I have on a slide at the very end that I just finished reading, and she references inflammaging throughout the book. Really, more than half of women will have arthralgia or some type of joint pain during this phase of life. Estrogen is a natural anti-inflammatory. So when the estrogen levels drop, this is when inflammation can become much more difficult to manage. We also experience in this time a change in body composition. As I mentioned, there is an increase in visceral fat during this phase. So an adipose tissue is an active endocrine organ. Isn't that interesting? That produces pro-inflammatory substances that are called adipoconate. I can't say that. I practiced. It produces pro-inflammatory substances that mean that these signals are circulating in the bloodstream and the body, and certainly make it harder to combat some of these inflammatory conditions. And the gut can also be a contributing factor. Changes in hormone levels can lead to an imbalance in gut bacteria. This is known as dysbiosis. This allows toxins and undigested food to enter our bloodstream, and this can trigger a systemic inflammatory response. So there are numerous factors that can contribute to this inflammaging during this stage of life. Number two is sarcopenia. This is a term I think we're probably all familiar with, but what it is a progressive loss of mass, strength, and function of our muscles. Here you can see kind of some cross sections of the upper thigh in a 35-year-old, a 55-year-old, and an 85-year-old female. Appreciate the decrease in muscle size and the increase in adipose tissue that occurs, especially by the age of 85. Clinically, it's defined by loss of mass, and this can be measured with DEXA scans, some bioelectrical impedance, or MRIs. Decreased muscle strength, and there are some really well validated grip strength tests to kind of measure that, and a reduced physical performance. Obviously, women are slower with walking, they may have difficulty navigating stairs. The quadriceps are actually one of the first muscles to be impacted with sarcopenia. So that's something to kind of for us to keep in mind as we are working with these patients. How does sarcopenia progress? So, adults reach their peak mass around the age of in their late 20s. So, around the age of 30, muscle mass does begin a slow decline by about 3 to 8% every decade. After menopause, this rate accelerates to the point where women lose 1 to 2% of mass in their muscles per year and 3% per year in strength. I do want to say that with training, these numbers are modifiable and actually preventable. So it sounds a little doom and gloom, but it is, obviously something that women can work on and decrease the level of decline that they experience. Type 2 fibers are the primary ones that we lose first, responsible for quick responsive movement. And if you think about it, really, they're important for fall prevention. As I mentioned, research indicates that the quadriceps are particularly vulnerable, especially to the loss of type 2 fibers. So, something for us to be thinking about when we are training these women. Notice too that strength in this menopausal age group does decline faster than mass. So, we lose about 3% per year strength wise and about 1 to 2% in mass. So, what does that mean? It means that a woman might kind of present as the same size, and yet she is weaker and less stable overall. So, we can't always look by appearance, especially in the early stages in perimenopause and early perimenopause, and I'm sorry, early menopause. This may not be evident right away. So something to keep in mind, though, we can't always see what's happening, and it is important for us to keep in mind how to prevent further decline as a woman ages. I did want to talk about the grip strength and just kind of mention some targets here. These are, based on the right hand, as 90% of adults are right hand dominant. And these are the targets. So, if we have a dynamometer in the clinic, you can actually have your patients, kind of do some grip testing to see if they can reach kind of the targets. If not, there are some very good studies out there that show if they cannot reach the minimum here, there is a higher rate of mortality and morbidity among those patients, and they probably need to work on their muscle mass and muscle strength. A couple ways to maybe incorporate improving grip strength with patients would be things like farmer carries, suitcase carries, maybe dead hangs from a bar, wrist curls and extensions, things like that, that we can work on with these patients to help. So just put that in here so we have kind of some guidelines. The third thing that Dr. Wright talks about is the decrease in bone density. And really, when we think about bone density, it is absolutely a silent disease. It's not something that we can see. It's often not something that people are even aware that they have until they have a fracture. Unfortunately, menopause accelerates bone loss. Due to the drop in estrogen, and estrogen is very strong help in keeping our bones dense. So we can lose about 10% of bone mass in the first 5 years postmenopausally. So that's fairly significant. About 200 million women in the world have osteoporosis. about 30 to 50% of them actually will experience a fracture in their life. And as we know, fractures can really lead to long-term chronic pain, disability, and certain fractures can even lead to death. So the prevention of this is key. We will talk about this later as I go on further. I will say too, women that have an earlier onset of menopause are at a higher risk of low bone density because if they have early menopause, estrogen declines sooner. So their risk of early onset of bone density does kind of rise at that time as well. What are the risk factors for developing low bone density? You can see the major risk factors here. So any type of fracture as an adult actually increases your risk. If you have a first degree relative who's had a fracture, Caucasian and Asian postpartum women are at higher risk, and being of low body weight, under 127 pounds. Smokers are at higher risk, and if you've used any form of corticosteroids orally for more than 3 months. In the United States, the way that we primarily assess for bone density is with a DEXA scan. Fortunately, in the United States, DEXA scans are not paid for until a woman is 65 years old or older. And as we talked about, menopause on average is 51 years old, 51 to 52 years old. So I would argue that 14 years after the onset of menopause, is a little too late. By that point, we're really finding that, women may have severe bone loss. So my recommendation is if you present with any of the major risk factors, you can talk to your provider about ordering a DEXA scan. I will be requesting a DEXA scan myself. I hit a couple of those major risk factors. And so if you have one or more of them, insurance will pay for it before the age of 65. This is a broad generalization, but we're finding many of them are covering it. So it's worth requesting and worth being proactive to see if you can find out where your baseline density is, and then work preventatively to keep this from worsening over your lifespan. You might want to get in the habit of looking at your patient's DEXA scans if they happen to have them. Certainly pull up their scores and see what their T-score measures. That's really their score that tells you where their bone density is. Most of us have had some education in this, so obviously a T-score tells you really whether they're in a normal range, osteopenic, or fall into the category of osteoporosis. A patient between a T-score of -1 and -2.5 is osteopenic. And then if they are even higher than -1 or -2.5, that falls into the category of osteoporotic. That's not doom and gloom, though. Even women with osteoporosis, they can reverse it with medication and absolutely with exercise. That's critical. So we serve a big role to help patients who present with lower bone density. You can also talk to your patients about some supplementation that they can do, and they should be talking to their physicians about this as well. But the recommended calcium guidelines for a female over the age of 50 is 1,200 to 1,500 milligrams a day. It is advised that also there be some D3 as well with the calcium, because that helps with absorption, and also because people are chronically low in D3, vitamin D, especially if they live in the northeastern part of the United States like we do. Vitamin D is recommended at 800 to 1,000 IUs daily, and that's something that's easily measured on a blood test. Many of my patients actually tend to take higher doses of vitamin D. And it's beyond the scope of this presentation, but low vitamin D can certainly present with a lot of muscle dysfunction and muscle pain. So that's a worthy blood test to have. And of course, we're recommending that they do a lot of weight bearing and weightlifting, obviously keeping in mind the degree of severity of their osteoporosis and being mindful of their posture and technique when they do so. Number 4, that Dr. Wright speaks of is the breakdown of cartilage. Estrogen absolutely can keep cartilage intact. So as estrogen declines, it can begin to break down. We lose our joint lubricating effects that estrogen provides, and chondrocytes within the cartilage begin to deteriorate faster. So that cartilage becomes stiff and brittle. Obviously, this leads to a higher risk of osteoarthritis. There are five main areas that affect women with major cartilage breakdown during this phase: the shoulders, knees, hands, hips, and of course the discs of the spine. I would speak a little bit, or I want to speak a little bit, particularly about the shoulders. Adhesive capsulitis is something that affects majority of women between the ages of 40 and 60. So if you kind of think about your patient population, think about the patients that you've treated with frozen shoulder, I would bet that the vast majority of them have been women in the perimenopausal to menopausal ages. And why? Well, there are estrogen receptors actually in every system of the body, but in particular in the synovium of the shoulder. So as estrogen declines, those estrogen receptors have nothing to connect to them, and this can drastically impact the cartilage in this area. As I was preparing for today, I discovered that in areas of Asia, frozen shoulder is actually called 50-year-old woman syndrome. So it's something to kind of keep in mind, and it really explains really how cartilage is drastically impacted in this, in this age demographic. And number five, loss of satellite cells, also known as stem cells. So these are cells that are released when a muscle fiber is injured. So this has to do with muscle repair. And estradiol, remember that's the most common form of estrogen in a premenopausal woman. It's responsible for stimulating muscle cells to begin to repair. When estrogen declines or estradiol declines, recovery from injury is much slower and much less efficient. So not only do we have the sequela of symptoms that I've already spoken about, but then the repair of our bodies actually is a little bit impacted by loss of, and repair of our muscles is impacted by the decline in estrogen as well. So what do we tell our patients? How do we begin to address this? Dr. Wright, being that she is an orthopedic surgeon and she deals with athletes and she deals with exercise physiologists all the time, she actually had some specific recommendations on how women can approach this phase of their life. Number one, move often and lift heavy. That is a mantra that she repeats often in her podcast, in her book, and things that I've spent some time delving into. She absolutely recommends that women use heavy weights, which of course is subjective. So heavy means enough to exhaust a muscle after 3 to 6 repetitions. That is much lower than I think we tend to think with our patient population. And heavy may be just body weight. Someone may start with just, the weight of their arms, but really we should be progressing them or having them progress themselves with the weight and the resistance, so that they can perform 3 to 6 reps, take a break, and do 4 sets of that. It is recommended that the strength training is performed 2 times a week. And this is all evidence-based, what I have listed here. And then moderate aerobic exercise for 150 minutes. And it is recommended that that would occur in at least zone 2, which you can see here is at about 60 to 70% of the maximum heart rate. So it includes both aerobic exercise and weightlifting at least twice a week. This is really what would be very beneficial to address some of these symptoms and prevent, muscular decline. Recovery and sleep is another important issue to think about. During sleep, we release growth hormone to help with repair. As I talked about, stem cells are impacted with low estrogen. So, getting as much sleep and recovery time as possible is very beneficial. As many of us know, probably chronic stress can make this challenging. And this is often a phase of life when women are in that sandwich generation where they might be still rearing children, but then also caring for aging parents and potentially, kind of in the height of their careers. So there's many, many stressors that can be impacting them. So kind of prioritizing sleep, trying to get 7 to 8 hours is very helpful in this phase. It's easier said than done, but there are some strategies out there, and it might be helpful talking to your patients about this. And considering menopausal hormone therapy. So this is something that used to be called HRT for those who are in the know or maybe have been, paying attention to this patient, this time in a woman's life. We used to call it hormone replacement therapy. It's now the more preferred term is menopause hormone therapy. And there is strong evidence that menopausal hormone therapy can help slow bone resorption and reduce the risk of fractures within the hip, spine, and wrist. It is the number one recommended um, pharmacological solution for low bone density. There's strong evidence to support it. There's also strong evidence that MHT can control hot flashes and help impact the genitourinary syndrome of menopause, which I have not even touched on yet today, and I will not be. It's not within the scope of this, but I hope I can do another grand rounds on that topic at some point, being that I am a pelvic health physical therapist. There is moderate evidence that MHT can have some benefits preserving strength and muscle mass when it's combined with exercise. There is not strong evidence in this, and I would argue it is because the use of MHT has been markedly limited over the past 25 years. So it's not that it doesn't have a benefit, it's actually just the fact that women have not taken hormone therapy for about actually the past 24 years. And I will explain why in just a minute. But you'll see here that if someone were to use menopausal hormone therapy, which is usually in the form of estrogen alone or estrogen combined with progesterone, it's best optimally beneficial during the first 10 years postmenopausally. So research indicates that's when it should be prescribed. So I want to talk about the Women's Health Initiative study related to hormone therapy. So this study was one of the largest studies of its kind. The study began in 1991. And if you talk to any gynecologist, any like OBGYNs, any woman in the women's health field, anyone in the menopause field, everybody knows what happened in the WHI. It's kind of important that we talk about this. The study began in 1991. It was huge. It was almost $1 billion study at that time. And there were over 160,000 women enrolled. As you can see, they were in the state of menopause. So they were aged between the ages of 50 to 79. It was a double-blind study. It included women taking just estrogen alone or estrogen plus progestin or a placebo. And the reason they would take estrogen alone, those would be women who had had hysterectomies. So that was why they were in that category. Those who had to take progesterone were women who still had their uteruses, and progesterone actually can thicken the uterine lining. So the reason women took that was to make sure that they didn't develop hyperplasia within their uteruses. So basically, there were two arms of types of hormone replacement and then a placebo group. At the time, so in 1991, hormone therapy was widely used for symptom relief, and it was believed to protect heart health. That was the main reason for the study, was to see if estrogen was cardioprotective. But they were also measuring many other health metrics, and because it was such a vast number of women involved in this study. So again, it started in 1991. In July of 2002, the WHI study was abruptly halted with the estrogen and progestin group of participants. So this involved tens of thousands of women. The Safety Monitoring Board decided to stop the trial because they were reporting that invasive breast cancer and cardiovascular events outweighed the benefits of the cohort of women who were taking hormone replacement in the study. Apparently, if you talk to any OBGYNs who were working in 2002, this was a day that they will not forget. doctor that I've spoken with says the phones were ringing off the hook. Patients were reaching out to them. What should I do? Should I stop my hormone therapy? Am I going to develop breast cancer? What have I done? How do I mitigate this? It was a really drastic event within the world of OBGYN at the time. In that fall, so still 2002, the results were published. And in fact, the researchers of the study, there were two head researchers, they actually went on the Today Show and they talked about their findings, which then made the overall panic actually rise exponentially as they went on national television and to describe it. As a result, there was a rapid decline in the prescribing of menopausal hormone therapy starting in 2002. Unfortunately, there were numerous problems with the Women's Health Initiative. Number one, the average age of the female in the study was 63 years old. And if you recall, the average age of the onset of menopause is 51 to 52. So these women were starting their hormone journeys much later than would typically be common. And if there were cardiovascular changes, if there was any predisposition to breast cancer, they were a little bit older and already had some higher risk factors. The risks were then overgeneralized to apply to all women. So they did not account for age and they did not account for timing as far as when the estrogen was begun. Analyses were performed years later that found that younger women, so in their as soon as menopause started in their early 50s, had much drastic and much safer outcomes taking menopausal hormone replacement. And unfortunately, it does seem as though the media kind of went crazy with this and exaggerated the risks, and there was not a lot of context reported, so women were just very frightened. As I have experienced as a clinician working with women, many women, if right now, even in 2026, if I talk to them about estrogen replacement or any form of hormone replacement, there's a lot of pushback within just the general population, thinking that it is going to cause them breast cancer. And these findings have been absolutely debunked, especially if hormone therapy is started in the much younger population and either in perimenopause or early onset of menopause. So there has been a lot of discussion about this in the past few years in the world of women's health. And November 10th of last year, there was a black box warning on estrogen that was finally removed. The FDA announced steps to remove language that labeled estrogen as potentially increasing cardiovascular disease, breast cancer, and probable dementia. So the warnings have been removed. A lot of people within the field have worked really hard to get the FDA to remove those warnings. And the FDA has stated that the risks were misinterpreted and that HRT or, MHT provides an overall benefit to women within the first 10 years of menopause onset or before the age of 60. So what has happened? Well, there is an entire generation of women who did not receive hormone replacement therapy. So from 2002 until really just the past few years, there is a generation of women who have experienced the effects of low estrogen and were offered no medical support in that realm to help prevent numerous symptoms. That leads me to bring up a case study. And in fact, this is my aunt. I don't want to release her true name, so I'm going to call her Aunt Sarah. I saw Aunt Sarah about 2 weeks ago. She is 76 years old. She is very active or was very active, I would say, as a 76-year-old. I'll run through here her medical history. She has had numerous basal cell carcinomas removed from her face because she was a child of the 70s and 80s, apparently. No sunscreen, used to self tan or used to tan all the time. So that's her biggest medical problem, aside from she does have osteoporosis as well, and she does have some anxiety. So overall, her health is pretty good for this age group. She has two daughters. They were born vaginally. She entered menopause right at the age of 52. She never received menopausal hormone replacement because she fell exactly into this age demographic where when she became menopausal, it was right around 2002 when the Women's Health Initiative released its findings. So she was not put on hormone replacement. She is an avid walker, loves to walk. She walks an average of 45 miles a day, really enjoys working in her garden. She did have a total knee replacement 4 months ago. And again, I saw her 2 weeks ago. As of now, 4 months post, she has persistent joint stiffness. She's got limited range of motion. I was noticing her difficulty with transfers and navigating stairs. She actually had a fall while we were out together. She fell just getting up out of a bench that she was sitting on, and no drastic injury, but that's just not like her, from the Aunt Sarah that I'm familiar with. She has slower gait speed. Her balance obviously is impaired. So she's now fearful to move. She's got some instability. She has fragility of her bones. She is, afraid that she'll never get back to her 4 mile walks. And it has a drastic impact on her life. So what is the clinical context here? What has happened with Aunt Sarah? Well, she did not receive hormone therapy after menopause, and I do believe this has led to her accelerated bone loss. If you remember, there is strong evidence that hormone replacement can prevent that loss of bone density, and she kind of missed out on that opportunity. She now has osteoporosis. I did ask her what her T scores were, and she's minus 3.1 in her hip, and I don't recall, I think it's minus 2.8 in her spine. So she absolutely has fairly advanced osteoporosis at this time. And, her soft tissue quality now isn't as good at this point as she's recovering from this total knee replacement. She just doesn't have the elasticity and the collagen that we would hope she had. And if she had potentially been on menopausal hormone therapy, I don't know, where she would be if she would ever have needed a knee replacement. I don't want to really say that this is the magic pill and the answer to every problem. In fact, there are a number of women who are not really eligible to take estrogen replacement therapy or hormone therapy, especially if they've had some form of gynecological cancer, so breast cancer, ovarian cancer, cervical cancer. Generally, they're not going to be prescribed menopausal hormone therapy, but it really can be quite helpful. And again, the women that we are working with and that we are seeing right now as physical therapists in their late 60s, 70s, early 80s, they most likely never had any form of hormone therapy. And I would ask you to query them and find out if they ever did. It is kind of an interesting thing for us to consider. So, this is a family member of mine. And so I'm thinking, what am I doing personally so that I don't become like my Aunt Sarah? I questioned whether I was going to share this, but I figure we're all friends here. So I'm going to let you know that I am 51. I fall right at that window of, the average age of menopause. I am perimenopausal, that I will share. And, so I'm thinking, what am I going to do? How can I prevent, maybe being the way my Aunt Sarah is at the age of 76. So I have changed my routine a little bit. I am no longer running as extensively as I used to. I think many people know I've done a number of marathons, half marathons. I'm not running long distance at this stage. I am still running. I do find that, I need the cardiovascular benefit, but I'm also doing strength training and pretty heavy strength training about 3 times a week. I'm prioritizing bounding in impact and high quick movements. Again, to prevent the loss of those fast twitch fibers. And I'm trying to sleep better. I've got some coworkers holding me to accountability here. So that's helpful. And they happen to be in the room with me here. So really trying to work on sleep. That's something that I'm finding is a struggle for me. And my Aura ring tells me I'm not getting much deep sleep right now, which is the sleep type that is highly affected in perimenopause. So I do think I need to kind of address that. I am going to request a DEXA scan. Since I spoke to my aunt 2 weeks ago and realized where her T scores are. I'm going to request with my family doctor a DEXA scan to see where my baseline bone density is as I enter into this stage of life. And I do think that is, within the realm of reason, since I do have a family member. My grandmother had osteoporosis, and apparently my great grandmother was that very osteoporotic spine where she was extremely bent over and couldn't even look up, to see. She was her head, her spine was very, very forward flexed. I never met her, but knowing that I have that in my gene pool, something I feel that would I want to kind of look into. Um, and I am going to be looking into menopausal hormone therapy shortly. So I would say also the idea of the fear of taking, estrogen replacement has been embedded in me for years. My mom was diagnosed with breast cancer at the age of 40, and she passed away at the age of 48. So for years, I always said, I will never take estrogen. That would put me at increased risk. I shared that with patients. I shared that with family members. I was, living the mindset of the results of the Women's Health Initiative. And at this point, now that I think I've learned more and, research has come out to support that this does not increase the risk of breast cancer, I'm absolutely looking forward to starting menopausal hormone therapy, hopefully shortly. I would say it is something that you could talk to your patients about. They probably need to speak to a menopause provider. Within our health network here, there are 7 OBGYNs who are certified through the North American Menopause Society, which is now just called the Menopause Society. So they are specially trained to help women navigate this phase of life. However, there are also physicians who may not be, certified through the Menopause Society, but also have education in this. So I would you really ask your patients to query their providers how well versed they feel in helping them navigate this stage of life. If their regular doctor says, I don't know a lot about how to help you with menopause, or their OBGYN may also say that, they may want to seek out another doctor. And the best recommendations that I have are to tell your patients to go to menopause.org. They can search for doctors within their zip code, and they can find providers. Like I said, we have a number of them here at St. Luke's who can help them with, kind of figuring out how to navigate this stage. So what do we do? How do we provide the best care for our patients? I don't have to read this. This is PT right here. These are things that we do. We know what to do. We know how to strength train. We know how to do balance training. We know how to do flexibility exercises. So if you do these things with the patients who present with the musculoskeletal syndrome of menopause, you will be doing very good care for your patients. But I would argue that you can actually do excellent care for your patients and consider all of the previous treatments, but then educate your patients on menopause-related musculoskeletal changes and how they can manage this themselves. Ask them where they are in their menstrual history. If you have a patient in their 40s or older, I think this should be a question to be asking them. Are they using hormone replacement? Are they considering hormone replacement? How are they sleeping? What is their stress level like? And what are they doing for exercise? All of these things are ways that you can mitigate this stage and really kind of help to navigate this with, kind of better overall health and well-being. And finally, coordinate with other healthcare providers, as I've already talked about. So I put together, I'm just about done, just a couple websites that I think are helpful. There's some great names out there. You might if you need these, if you don't have an opportunity to take a screenshot or take a picture with your phone, I am happy to share these with you, but I highly recommend them. They're all evidence-based. There are some great podcasts out there. The one that I'm really enjoying right now, it's called Ovary Active. And that's two OBGYNs, they're part of the Menopause Society. Everything they say is menopause based, but it is really entertaining, really easy listening, and very informative. So I highly recommend Ovary Active if you are wanting to learn more. And then finally, there are a number of books out there as well. I have most of these. And I am, if from an exercise standpoint, the two that I really enjoyed are Next Level by Dr. Stacy Sims. She talks about a lot of high impact and fast twitch movements and why they're important, and not to be afraid to work with your patients who have osteoporosis. We can load them as long as we're being safe and mindful of posture and things like that. And Unbreakable is the book that Dr. Wright, who obviously coined this term, is a book that she released in the end of 2025, and it is excellent. So that is my presentation. I am happy to answer any questions if there are any.
So feel free to unmute yourself and ask, or type into the chat, which we have a question in the chat. What are your thoughts on gluteal tendinopathy and gluteal pain in perimenopausal and menopausal women? I have had a number of patients over the years that have this chronic pain with very little improvement in symptoms, with long courses of traditional conservative treatment and other modalities. Advice for treating those patients.
Yeah, so that would go along with, the idea of how cartilage is certainly impacted during this phase. And I would agree with you. I do see a lot of gluteal tendinopathy as well. That's interesting. Yeah, that's not one that I came across in my research as far as joints in the body that are impacted. There was a lot of discussion of the shoulder and of the knee. So it might be worth, querying your patients. Where are you? Like I had mentioned, where are you in your, kind of in your reproductive life? How long have you been menopausal? You can talk to them about the impact on cartilage and on, kind of sarcopenia, how that can happen. They may want to consider a little bit of supplements that they would want to maybe talk to their doctor about, but I would absolutely check their vitamin D levels. You may even want to see, depending on her age, you may want to see if she's able to take some creatine. That has actually been shown to help with some muscle pain and tendinopathies as well. So there are some, kind of things out there that you could consider offering to your patient. But that's a good question.
Thank you.
Mm-hmm.
Other questions?
Yeah, there's one in the room here.
You mentioned that strength training and heavy strength training is advised for these patients for their symptoms, but you also mentioned that muscle recovery is impaired because of the low estrogen. Are you finding that when we load these women with heavy strength training that they are more sore than you would expect? And how do you manage that?
Yeah,
them?
That's a great question. I think it's all relative. So when we say heavy lifting, we have to start and meet that patient where she's at. So, we're going to be starting, like I said, sometimes heavy for her, it might be a 2-pound dumbbell, and so that might be the level that she's able to lift those 3 repetitions before failure. And then that's where we stop. What the guidelines that Dr. Wright mentions are kind of what we're working towards. It may not be where we're starting. So, you may want to kind of, maybe you're not doing, 3 to 6 reps times 4 cycles from the get-go. I would slowly kind of add some things in, and then as you work with her, pay attention to how she's feeling with soreness and pain, and kind of build from there. So yeah, she's probably going to need more rest breaks maybe than, some of our younger patients. But I think we're afraid. We see patients who look frail, and we're afraid to kind of, to strengthen them. And really, I think we're doing a disservice if we don't take that into consideration. But yes, we have to pace them probably within their abilities. So that's a good question. They might be a little bit slower to increase as we go. Yeah.
Awesome. Another question online. Have you seen more patients with a history of cancer or chemotherapy with more progressive bone loss than their chronological peers?
Hmm. I don't know that I have seen that correlation personally. Melinda Styling's in the room. She might be a good one. I don't know, Melinda, because working with some, I don't see a ton of patients with cancer, quite frankly. But I don't know. I haven't seen that in the research that I have done. I have not seen a correlation necessarily. I would think energy levels would be impacted, and that might be something. Any thoughts? Can I put you on the spot, Melinda? And I'm wondering if you see
Keeping it
anything.
in the scope of musculoskeletal syndrome and menopause,
Right.
I think that when we think about our cancer survivors, those that are going through hormone suppression therapy for breast cancers or gynecologic cancers are being put into that medical menopause that Lauren mentioned. And so appreciating that they have been in this very rapid
Yes.
medical menopause will then impact their bone density in all the ways that Lauren already mentioned. But chemotherapy and other cancer treatments and the effect on bone density is kind of outside of the scope of what we're talking about.
Yeah, but that is a great question because those patients are generally not patients that will be put on menopausal hormone therapy. So that's right. So they may well be impacted more drastically than those who can take some. Yeah.
Gotcha. Now, we do have another question, and I will ask it in just a moment, but just in the interest of time, I know people will need to sign off shortly. So make sure that you take the quiz and the course evaluation in order to get your course certificate. And if anybody else wants to stick around, we have another question. So I have a patient who has a history of two femur fractures. She is now taking hormone replacements via injection. She has asked me questions about if she should be taking them long term. I said I didn't know. Have you had any patients with this?
So that's not our scope to determine how long patients should be taking menopausal hormone therapy. And I didn't really go into a lot of detail as to how this is administered because I frankly didn't have time. But yeah, so anyway, real quickly, estrogen replacement can happen through oral ways, through injections, as mentioned. There's patches, and generally there are vaginal rings. So those are kind of the four avenues of administrating menopausal hormone therapy. My understanding is that this should be a discussion that is made with whoever is prescribing it, and there is no end date necessarily when it has to stop. So when we think about how it is bone protective, and we are thinking it's cardioprotective, although we don't have great evidence. But I do think as more and more women are going to be starting to use menopausal hormone therapy again, more research will be supportive of that. There is not a huge kind of push to stop it. So that I wouldn't expect a PT to know the answer to that. I'd say that's a question to ask the providing doctor, whoever has the patient on that menopausal hormone therapy. How long or how quickly do we see results? Often they say it's within about 2 to 3 months. So I'm not sure how long your patient's been taking it, but if it is providing any sort of benefit, I would think she may have noticed something, or she should notice something, hopefully, within that time frame.
Cool. The next one actually dovetails off of Dr. Steinland's earlier question about exercise and resistance training and soreness. Do patients eventually begin to adapt to resistance training, and does recovery in this population get better with exercise?
Yes, to both.
Wonderful.
Mm-hmm. Yeah, I think encouraging patients is important because it might be something new for them. may not have been something that they've ever done in their lifespan, but absolutely, yes, it's the more you do it, the more resilient the body becomes, and yes, they should feel better as they go.
Wonderful.
Mhm.
So does another question. So does taking hormonal replacement therapy prior or during menopause decrease the risk of cancer development as compared to an individual who is not taking it? Yeah.
Um, Evidence is more so related to if it increases the risk of breast cancer, not whether it decreases the risk, at least in my understanding. So, in other words, the data that came out that has since been debunked is that menopausal hormone therapy does not correlate with an increased risk of breast cancer, but it is not something that's considered prevention. In fact, if we do consider that breast cancer is typically um, fed, for lack of a better word, by estrogen, I would not think it would be preventative of a disease. Yeah.
Excellent. So if anybody has any further questions, please feel free to reach out either directly to Dr. Garges or to myself, and we will get you an answer as quickly as possible. Um, Again, make sure you take your quiz, make sure you take your complete the course evaluation, and provide us with additional feedback on what you want to see in the future. Thank you very much for attending, and if yeah, and I'll see you next month.
Thank you.